Thank you.
Good morning, everybody, and welcome to episode 2 in our how-to guide about setting up a digitally supported COVID-19 service for people at home. Last time we talked about the experience in Hertfordshire and we talked about a virtual ward model, and this week we're turning to primary care. We're going to be talking about the primary care hot hub experience in West London. Delighted to be joined by Tony Willis and Kuldhir Johal. Tony is a GP in Shepherd's Bush, and he's also a clinical director for diabetes across the group of Northwest London Health and Care Partnership, which is 8 CCGs. He's also the lead for clinical informatics. And Kuldhir is a GP in Northwood, which is in Hillingdon, and she is also interested in IT by her clinical IT leadership, and she's also the vice chair across Hillingdon as governing board for its CCG. The idea today is that Tony and Kuldhir are going to talk as if a long-standing colleague came over for a cup of tea and said, how did you do that thing? I would really like to. So it's a very honest, nitty-gritty, practical guide. So if you would like to set one of these up, perhaps as part of your response in the event of a second wave, hopefully you will learn all you need to know here. And at the end of the main session with Tony and Kuldhir, I'll come in and tell you a little bit about some of the resources that we have in support. I should have mentioned that I'm Tara Donnelly and I'm the Chief Digital Officer at NHSX. And we'll then go into questions. So please do put your questions in the chat as you go. You can vote and like questions that you think are particularly interesting, and we will aim to answer as many of those as we can in our final session, which will include a number of other colleagues, including Lisa Hollins, my deputy, and Chris Richmond, our head of delivery. But I'll hand over now to Tony, who's going to tell you about how this all began in Northwest London. Tony.
Hi, thanks, Tara, and really fantastic to be able to present some of the work that we've been doing. So I'm going to cover some of the background. Can we have the next slide? So I'll cover some of the programme background, the project setup, and some of our thoughts about the next steps, and Kuldhir will focus on outcomes and evaluation of the programme to date. So just a little bit about the project background. So if you can go on to the next slide, please. And the next one, so Northwest London is a large area. It's got a population of 2.4 million, and it's a very diverse population. And it was one of the areas that got most affected by COVID in the early days. So looking at our background, so just going back a little bit to this time last year, we were successful in winning a bid to become one of 5 health data research UK funded hubs. Next slide, please. Of which part was a fully evaluated type 2 diabetes exemplar focusing on remote care intensification as one of the key projects. And so we began working on quite a detailed project design programme in January 2020 in conjunction with a global digital health team from AstraZeneca. They were one of the key industry partners within this digital innovation hub. So next slide. As COVID emerged, we rapidly realised that people with diabetes were going to face a very significant threat from the data that was coming out of China. So we looked to see how we could morph our programme into supporting people as they developed COVID in the early stage of the UK pandemic. So moving on to the next slide. And fairly rapidly, part of what we tried to do was put together some standardised data entry templates for primary care on both System 1 and EMIS. And this was based on the understanding that data was going to be crucial, both in our understanding of the spread of COVID within the area, but also for retrospective analysis. And I think Kuldhir will emphasise this point even more so about the importance of data capture and data entry as a key part of the analytics. So we put some mandatory data fields onto the templates in order to allow this this retrospective analysis and the real-time analysis of what was going on. And these are our data trends. So we started capturing standardized primary care data in early March and began to see this exponential growth. We began capturing breathlessness symptoms towards the end of March, and then Further on from that, we used the Pan-London COVID protocol with its RAG rating for severity to understand the severity of the patients developing COVID. There's a question here about whether we'll be sharing the slides. Yes, we will. So we will go through them fairly quickly because there's a lot to cover. So moving on, the other key thing that North West London did was to commission some hot hubs. We call these escalated care clinics to allow the examination of people with COVID symptoms who potentially needed more support. And that was commissioned locally by the CCGs. But it was clear early on that monitoring of large numbers of patients at high risk of deterioration within the community was going to be one of the key COVID battlegrounds. And we were fortunate to be in a good position to work with the NHS COVID-19 Task Force, remote monitoring team, and the team from AstraZeneca who were seconded into NHSX to support the project. So I'll talk a little bit about the project implementation. Next slide, and then on to the one after that. So what was it that we were looking to do? We were looking at two specific aims. One was the remote management of the care of patients in the community who are deemed to have moderate symptoms, who could potentially rapidly become severe and require hospitalisation, and also to set up a virtual ward system to allow scaling of remote support. Next slide. So our focus was particularly compared with the other two projects was focusing on patients in primary care, as that was the area that most of the patients were situated. And that was both patients triaged from 111, but also those triaged from face-to-face or remote consultations at the hot hub. Next slide. As part of the project, we rapidly identified the importance of remote monitoring as a key part of the solution, with a requirement for near real-time reporting of things like oxygen saturation, pulse rates and symptoms multiple times daily. And we knew that staff would rapidly become overwhelmed if all of this required manual processing. So we're looking for a tech-enabled solution. And that's outlined here. Our expectation was that the tech-enabled remote monitoring solution would allow rapid identification of deteriorating patients in particular, but also being able to improve productivity and improve patient outcomes along with other system benefits. Moving on. So Metapad were, interestingly enough, they were already engaged with us in the HDR UK funded hub as one of the industry partners, and had also been evaluated by NHSX as one of the potential tech solutions. So it seemed like a good fit. The system was going to be quick to configure, and they'd already developed some of the key COVID monitoring modules and a clinician dashboard. So we knew that they had the technical capability and were therefore a good fit for us. Moving on. So the project team put together a very aggressive project timeline with a 4-week approval and launch timescale. And we had to cover a huge number of different work streams within that. So pathway mapping, coding and clinical template design, search development, standard operating procedures, information governance, clinical risk assessment and approval, app and dashboard configuration. So we had pretty much daily project meetings, very short, sort of half-an-hour project meetings with key leads involved, driving the progress of this project. The next slide. The very able team from AstraZeneca undertook some very detailed process and pathway mapping using virtual tools such as Miro, shown here for the pathway mapping, which allows project whiteboarding, but also Teams for collaborative documentation sharing. Next slide. So we use the Pan-London guidelines as the sort of key document for the clinical parts of the pathway to identify the cohort who'd be monitored and the pathways around those. And our focus was on these patients with moderate symptoms who didn't require hospitalisation but were at significant risk of deterioration. Next slide. And we mapped out the key processes for both the patients using the Medipad, but also importantly for patients who weren't able to use Medipad because they didn't have the technical capability or didn't have a suitable device. And we were asking patients to report in their symptoms 3 times a day or else to be called 3 times a day by one of the staff team. Again, next slide. One of the key parts of the project was identifying suitable codes within the system to standardize processes, but also to allow future audit and evaluation. And these were standardized across System 1 and EMIS and mapped to SNOMED codes. One of Kuldhir's team, next slide, was very helpful in developing the standard operating procedures so that we were able to use the other staff members, so allowing staff members to operate at the maximum of their capability to be able to support patients. So we had admin team and healthcare assistants doing quite a lot of the data capture work. And this is just an example of the standard operating procedure with screenshots from the clinical templates and the requirements that staff team are asked to do. All of this information will be shared. In addition to that, next slide, the information governance. So we covered off the hazard log and clinical safety case report, as well as the DPIA, the information sharing, interoperability service specification, and all the other information governance documentation that's required, and took these through the required local governance processes. Moving on. Next slide. There were also numerous governance gateways that we had to go through, both locally and also within the national team at NHSX. So aligning these components was a crucial part of the project. Next slide. So we managed to get from concept to the first patients being onboarded within the 4-week time frame. And that just shows some of the key milestones that were on that pathway. Next slide. So basically, this ended up being an experience that was simple for clinicians and patients. And Kuldhir will come on in a short while to discuss some of the experience. So next slide. So just some of our thoughts about how we expand this into other remote monitoring opportunities. So now, having done the COVID piece of work, we're now looking at how we expand this into people with type 2 diabetes, and this is going to be a fully evaluated pilot in conjunction with Imperial College, Medipad, and the AstraZeneca team again. Next slide. So our aim is to provide a 12-week service for high-risk patients using video group consultations, remote monitoring and digital health marketing, basically to provide a more intensified service for patients, reducing costs per patient and improving outcomes. So a lot of value that potentially creates within the system. Next slide. So this is just a sort of timeline of what that looks like. So risk stratification of type 2 patients, identifying the people at high risk, baselining, and then a 12-week project, a 12-week program of input with daily and weekly monitoring of patients, the video group consultations that allow collaborative goal setting and action planning in conjunction with patients, and also the twice weekly email content that covers a lot of that information, and then an evaluation at the end of it. So that's going to be, next slide, evaluated in the later part of next year as an overall system improvement, and then we expect to hopefully be able to scale this up across the patch. So I'm going to hand over to Kuldhir now, who will cover off a lot of the outcomes and evaluation of the COVID work. Thank you, Kuldhir.
Thank you, Tony. Next slide, please. So I've been a GP for over 20 years in my local patch and been very much involved in clinical IT during that time as well. And you've seen it evolve from handling Lloyd George notes through to just using computers for prescribing, and the brave new world we are all in now with remote consultations and working. Equally, in my role as a clinical commissioner, I've been doing this for over 10 years and have been very much involved in trying to align systems together, as well as working with the out-of-hours services, for example, the 111 service and the 999 in London. Next slide, please. So I will basically cover our experience and reflect on what we've learnt, but hopefully you will find it of value. What I won't cover is clinical pathways, as well as the detail around the MediPad app, primarily because Matthew kindly covered that in his presentation 2 weeks ago, but I will cover some of the elements he raised. Next slide, please. So our journey, as Tony's already alluded to, started back in March, and back then, even though we felt 3 to 4 weeks was a long time for any IT-related program, actually that was amazingly quick, because normally, historically, I've been involved in projects that can easily take up to 18 months. The important message here is, as Tony's alluded to, is we've got a lot of value around information governance, clinical safety logs, as well as detailed SOPs. As well as templates and search tools, which we will absolutely be very happy to share with yourselves. And even though we started off as 2 pilots within Northwest London, one with an EMA space, one with the System 1 base, we then shared our experience with the neighbouring 6 CCGs and managed to mobilise between the earliest, the quickest was within 4 days for one other CCG and up to 7 days with another. So I think that's another key message I want to convey, is that we're more than happy to share and learn together. Next slide, please. So as we've already alluded to, capturing the information was key. But one of the key points we all felt back in March, as I'm sure you all are very experienced with, is what was COVID? The textbooks are yet being written. They're still being written. Back then, we only knew it as a condition for about 2 months. And even then, on a week-by-week basis, the clinical guidance was changing. So one of the things that we wanted to learn about this was, what does it really mean for our local patients? More importantly, what can we do in primary care to help? And one of the key findings initially we found was actually, even though the national guidance was indicating BMIs of up to 28 or above, we were finding actually BMIs of 25 or above were becoming significant. Our cohort of patient was quite widespread, so we did manage to cover both young people as well as older people by using the 2 key arms of our virtual ward or remote monitoring. In other words, if you wanted to go onto an app, you could. Next slide, please. If you couldn't, then you could still use a telephone. And again, we broke this down. You can see this is the analysis I'll show you from Hillingdon as well as Central CCG. And it gives us a good idea of which population would use the app quite happily. But equally back then, we were analysing the data to determine what is a case mix. Interesting enough, almost 1 in 5 patients had no other pre-existing condition. And equally, the information has emerged about the connection with diabetes, BMI, and understandably, other comorbidities were already being identified from the information we were getting internationally. And over time, we found obviously those patients were being categorized as those requiring shielding. But again, the key message here is anyone can get COVID. And the one thing I always reflect on is COVID hasn't read the textbooks, and it is not discerning. Next slide, please. And the purpose of comparing 2 different sides was again to get an indication of, are we getting any consistency in messaging here? Next slide, please. The feedback we were getting from patients was very good, very supportive, and they found it of value. One of the key points to mention about the digital app that was being used by the patients was that there was a unique feature in it. For example, if a clinician looked at the dashboard and made an entry indicating they'd reviewed the readings for the patients, then the patient would get a double tick on their app. So it was a very unique way of actually ensuring there was interaction occurring without having to necessarily speak to anyone. Next slide, please. So one of the key points we wanted to answer the question about was, can primary care monitor these patients in the community setting, and is it safe? That was one of the key reasons that we put a lot of effort right at the beginning to make sure that our SOPs would be watertight, and there would be what I call a closed loop system of ensuring patient safety. Why? I'll touch on that later on. But initially, when I looked at 30 cases in more detail, we found some interesting patterns around the temperatures and the pulse oximetries, as well as the heart rate. Again, parameters that as a baseline we can do, but equally it all depends on whether you've got a pulse oximeter or thermometer. So we found that those were becoming key pieces of equipment. But do remember, you can have pieces of kit that aren't digitally. Bluetooth, as is a buzzword at the moment, you can use very simple tools to answer the questions. So next slide, please. So one of the key questions I started asking was, picking up more importantly, was even though we're told about very high temperatures, we were finding a lot of patients were having low temperatures. And again, we are exploring this further now. And again, one of the key personal lessons I've learned is if a patient is presenting with a low temperature, it's just an interesting reflection. I mean, I remember seeing a patient where I thought that the temperature was low and I thought there was something wrong with the thermometer. Actually, the temperature was generally low because it prompted you to put the pulse oximeter on and find that actually the O2 was low. Again, this is all why we're still learning and the guidelines were still evolving. Next slide, please. And again, this is the reflection that the majority of patients in our cohort actually had lower temperatures compared to the averages of the higher temperature. Next slide, please. So we did a detailed analysis on all of the patients that were admitted into both of the sites. And in relation to the Hillingdon area, I looked at those that went onto the Medipad app, as well as having the telephone arm. The important message there was that we had agreed very early on that we would monitor them up to 3 times a day. And we were very clinically heavy in the beginning to ensure clinical safety. And then over time, we were able to delegate duties to other members of staff and train them up. And that's really key. It's about having the right staff. It doesn't have to be a clinician 100% of the time. And do remember, we weren't offering a 24-hour service. We were doing 12 hours a day, 7 days a week. But how could we keep it safe? So one of the key findings initially was obviously about making sure is the data actually being captured, the data quality, because that's useful to know. But additionally, we were beginning to find patterns, as I've already alluded to. The most important thing we also started to pick up very early on was that there were other symptoms that patients were presenting with, and that was being recorded, such as atypical swelling, whether it was of the face or other limbs. And obviously over time we found that we are increasingly finding out about thromboembolic events occurring. Equally, we found obviously there were a lot of gastrointestinal symptoms being presented, as well as fatigue becoming a key feature. Equally, we also found fairly early on that a number of patients refused to go to hospital. So we were following the guidelines to indicate at what point clinically they needed to be sent in. But we were finding some patients were absolutely refusing, and I'll touch on that in a short while. Why is that important? At least we were still in a mechanism of being able to support them and undertake some form of intervention. Even if the intervention was a simple reminder of asking the patient to rest, that became quite key, as well as monitoring them regularly or giving them antibiotics or other methods of treatment. This is important going forward, I believe, purely because now that we've had at least 6 months of learning collectively, there may be some treatments that are available within the community setting, such as possibly dexamethasone, or under clinical supervision, different types of other therapies like oxygen. And again, I understand the guidelines are being looked at in relation to that, but it is about how can we support our patients going forwards. And thereby, the key point there was that there wasn't a single patient who had virtually no intervention. Almost 2/3 of the patients who were on either arm had some form of intervention. Next slide, please. And again, this is just a reflection of the importance of coding, as Tony's alluded to. We've all got the right tools in our systems, whether in primary care in particular, is almost the majority is computer-based. And if you manage to capture the information, you can look at the data and look at trends. Again, it's really powerful when you look at it on a case-by-case basis, because you can look at the trends for an individual case. The important message there is don't forget about clinical acumen and your gut feeling, and you know your patients well. But another reflection on the findings about oxygenation was almost 2/3 of the patients had some form of O2, some readings of O2 which were less than 95%. Next slide, please. And this is just a reflection of the importance of capturing temperature. But again, only 60% of the patients had this recorded, primarily because a lot of the recordings were done in the home setting. Not everybody had a thermometer. Is that something to consider going forwards? Next slide, please. So just reflection on a couple of cases. And the first case is regarding a lady very early on who was diagnosed, who was presented to a GP. And the GP felt, well, actually, it would be of value for her to be seen within the hot hub site. Within Hillingdon, we use EMIS, and we have the ability to do what we call cross-organisational booking. So the GP can do a telephone consultation and then book them into the hot hub appointment. Interestingly enough, when she presented at the hot hub, her saturations had deteriorated by the time she walked from the car to the hot hub consultation room. And again, indirectly, you could now, on reflection, say, well, actually, that's O2 following exertion. But again, these are all findings we were finding, and then she was obviously sent to the local hospital. The reason I'm mentioning all of this is because we mustn't forget about silent hypoxia. A patient may appear well on the phone at home, but do feel the value of assessing them and seeing them. And you can see from the timeline that she deteriorated over a matter of hours. She was subsequently treated in hospital, was found to have COVID pneumonia, and had some O2 therapy and was then sent home. Next slide, please. The next case is a lady who was on the Medipad app. For example, she was 60 years old, and she presented to a GP through the cross-organisational booking, had a telephone consultation through to the hot hub, and was monitored for a few days and then subsequently discharged. She then represented and was referred back, primarily because she went from having a dry cough to having a wet cough. At that moment in time, we were getting guidelines of monitoring patients from day 7 to 10, but actually clinically we were finding actually day 14 or later. And over time, we found that some patients were actually presenting later on in the illness. Therefore, it's about having the flexibility of determining for your local area the points at which you need to refer and how you want to monitor. In her particular case, it was, she was remonitored, found she was becoming more breathless, and then subsequently attended A&E. The reason I mention that is because even though this was picked up on the Medipad app and she had callbacks, the important thing is, as I mentioned, we weren't a 24-hour service, but actually the safety netting advice was given on each consultation and clearly documented in her records as well. She was also sent text reminders through the additional app, AccuRx, reminding of that when to call 111 and when to ask for an ambulance. So it is about empowering the patient to ask for help at the right time. In her particular case, again, she was noticed to have COVID pneumonia, was treated with O2 therapy and subsequently discharged home. Interestingly enough, her COVID swab was negative, but she subsequently went on to have a private antibody test done, which was subsequently positive. Again, the reason I'm mentioning this is we now have testing available, which is great. I know we all want more testing, which is even more important, but equally, don't forget, if a patient does have a negative swab, it doesn't necessarily mean they don't have COVID. Do remember the clinical picture. Another reflection on all the data that I've looked at in relation to over 200 cases now, is that a number of patients were being diagnosed as having exacerbation of asthma, even if they had asthma in their childhood. Think of COVID in those scenarios, purely because we're finding that as an occurrence. Next slide, please. So up to the middle of August, we were having over nearly 1,000 patients who were being referred by local GPs, and within Hillingdon we cover a population of 300,000, and there are about 44 practices participating, and our hub is centralised into what we call our confederation. A number of the referrals are also coming through the 111 service, so this gives a nice breakdown. But the reason I've given this as numbers is purely because you can, you know, reflect on, is it 1,000 coming through, 200 are from 111, 500 generated follow-ups, but actually gives you an idea of what numbers you can start looking at. And do remember that obviously this was from April through to August as the numbers were beginning to drop off at that point. And over time we found that actually almost 3/4 of the patients were followed up through telephone or through the app. Primarily at this moment in time, it's because it's older patients that we're monitoring, but as more and more younger patients come into the system, they may choose to use the app. The other key important thing we found was actually through the monitoring process, it wasn't that we weren't referring patients to a hospital, they were referred. But thankfully, fingers crossed so far, to date, all the patients that have been virtually monitored with in the Hillingdon programme, there's been no reported associated patient deaths. Next slide, please. So the key message here is that does a virtual ward strategy work, or in the new world, remote monitoring in relation to COVID? And the answer, at least we can give now, is a yes, because that was a key answer question we asked right at the beginning. But do remember, this is primarily a pre-hospital care service. And some of the key points of reflection are it does involve a mixed teams, mixed skill mix. It's the best way. Onboarding, offboarding is key. Knowing when to escalate. We had excellent support from our respiratory consultants as well in the event that they needed further advice. And do use the systems that you've got in place, and currently we're beginning to align it to our test and track as well as hospital discharges. Next slide, please. Why is this all important? The information coming out of secondary care is that clearly that a lot of patients who had saturations of 93% or lower ended up on ITU. Some of you will recall that way back in some areas, if a patient ended up having full ventilation, they either had a 1 in 2 chance, or if you were lucky, a 1 in 4 chance of actually walking out. That was really scary. It still is really scary. And that's one of the reasons that they're absolutely revisiting what is the right threshold for understanding what the PO2 readings are. But equally, do remember this is when they're in the severe state. And the key question for all of us was, what is the right reading we need to monitor within the community setting? Next slide, please. So again, what we've learned is silent hypoxia does exist. And equally, another key reflection is be wary of the patient who appears to be anxious on the phone. Are they truly anxious, or are they anxious because they're actually becoming hypoxic? Don't forget the silent asthmatic that you all may have had experience of meeting. The PO2 is really key in understanding what's going on. Next slide, please. So nationally, it's beginning to become very clear that the other key thing we all want to do is keep everyone safe, the patient safe as well as the clinicians. And that's why the theme of what we call the hot sites and cold sites has evolved. And it's a question whether you have a hub and spoke model within your local areas. Next slide, please. And another key reflection, right in the beginning, we learned that the numbers were going up. A lot of people refer back to the 1918 data. Is this the beginning of the first wave? Are we going into the second wave? And it was also a reflection on the right-hand side, how does all of this fit with the winter seasonal flus that we have, and how do we plan for the future? Next slide, please. So again, another key reflection from the national strategy now is primarily understanding that a lot of the monitoring will probably occur in some shape or form within the community setting, and how can we empower yourselves to deliver this? Next slide, please. Again, a key reflection is that a lot of the local clinical pathways are very similar, and but the important thing is being able to nuance it for your own local delivery. Next slide, please. So now a number of key other tools have become available. So there are examples of patient diaries that you can give, and there's no harm even making people aware of those diaries. A number of different languages are now available, and so you can give it to those in those languages as well. It is about making sure that people understand the importance of at least self-monitoring up to 3 times a day and knowing when to ask for extra help. Next slide, please. And if you click again. The important other key message is that we're all beginning to share our experiences. A key part of the sharing has been learning how to mobilize a clinical pathway. It's about how you implement in your local area. the important message there is there isn't one size fits all. You can nuance it to your own local delivery models, depending on what service provision you have. Next slide, please. So originally when we prepared these slides, we were going into a quiet phase, but I'm sure a lot of you will reflect it is getting busier. I'm a GP, like most people on the call. It is getting busy. You can sense it even on a day-to-day basis. But at the same time, nobody wants to quite go back to where we were back in March. And we know with respect that there will be an expectation that primary care will continue to deliver business as usual in relation to service delivery as well as secondary care. But how can we all collectively work together to step up to help deliver the care to our patients? Next slide, please. So I've reflected on some of the key messages, and we will be sharing these slides, but it's also about how we align the Pillar 2 results. I remember asking a few months ago, why can't we get the results? We now get them into our local GP systems. Do remember, if you get the Pillar 2 results or in the future Pillar 4 results and you have a positive patient, that you can take the opportunity for at least getting a baseline on how they are at the moment and making them aware of the service provision. Clinical safety was key to all of this, and it still is and will continue to be. But do remember, safety per se in relation to our workforce is key as well. Another key reflection was that you don't need to have an hour's presentation or an hour's meeting to understand how you can carry on delivering locally. We did almost on a daily basis 15-minute touchpoint calls. They were very powerful, and we learned a lot and we supported each other a lot. Next slide, please. Next slide, please. So as Tony and I have alluded to, we've got a lot of useful information, and Tara and the team are aware, as well as other forums as well, such as the National Deterioration Forum. All the same information is available. We're more than happy to share our experiences as well as examples of tools and templates, and all you need to do is adapt them. Next slide, please. So if you wanted to get going straight away today, one of the key information I keep asking everyone is get everyone's ethnicity, height and weight. We know what the BMI is then, and at the end of the day, we're all patients as well. So share your knowledge. Thank you for your time.
Thank you so much, Kuldhir and Tony. Fantastic. And as mentioned, we are trying to build together a library of as many resources as possible for people who'd like to adopt this model. We've got a dedicated web page on the NHS Futures site. We'll be putting the slides from today there later today, and there's a host of other resources on there, films, detailed things like SOPs, as you've heard, that are critical and will help save people time. We'll go into questions. We've got quite a few already. If we could just put the slide up with the details of the Innovation Collaborative site, that would be really helpful. We've also yesterday published a blueprint on this. It's available both at the GDE site, but also I asked Mira and the team, could she put a great big blue button on the Innovation Collaborative page? And my goodness, she's done it. You can't miss it. Click on that blue button and it'll take you through to the blueprint. The email address at the bottom, if you'd like to join our digital collaborative health space, email that, or indeed if there are any questions that you have, we would do our absolute best to support people who'd like to quickly move to this model in response to a second wave. We're recording today and we'll be publishing that certainly by the end of the week if you want to share it with colleagues, but we'll now go into some of your questions. There's a question about, does the care pathway utilise News 2 across the entire process pathway as well as its associated escalations? Would that be one, Kuldhir, that you could speak to?
So News 2 is available within GP systems, but not all GP systems were automatically recording it. But the key parameters, again, to inform News 2 are obviously things like your temperature, heart rate, blood pressure and pulse oximetry, as well as respiratory rate. We found very early on that trying to get an objective value of respiratory rate was very difficult. And so that's why we went for very much understanding what is the patient's perception of how breathless they're becoming. But in answer to your direct question, because I know News 2 is used a lot by the ambulance services, the urgent care system, as well as secondary care. And as part of the national evaluation, they are absolutely looking at that at this moment in time to determine what would be the correct thresholds going forwards.
There's also a question about, you mentioned 3 dementia patients. Were they reported directly to the cohort, or was that via a proxy access method?
So in relation to our dementia care patients, what we did was that if a patient needed to be assessed, they were referred into the service. It wasn't a question of determining what their underlying comorbidities was. So my audit or clinical case reviews was primarily looking at comorbidities after they'd been through the service. And that was when I then picked up the different cohorts of patients. The important message there is, again, no patients were excluded from the service. No patients should be excluded from the service, and actually families found it of value knowing that their patients and loved ones were being monitored irrespective of their comorbidities.
That's terrific. Jenny, we can take the slide down and then people listening can see the responder. A couple have been answered kindly in the chat. There's a question about, did we consider body-worn sensors as part of the data collection? Lisa's replied to that, but essentially the most significant clinical indicator was around hypoxia, so that was why we went after pulse oximetry, which was actually very hard to get hold of at that period. There was a global shortage of pulse oximeters in March and April, which is when this all stood up. It was also really important to keep it simple. So the way it works is the patient's own device, their own smartphone, they're sent an email, they can use an app to track what they're doing, and the only additional device is the pulse oximeter. You could add no end of things to that if you wanted to, but in terms of thinking of a simple, scalable model that gives the main clinical indications, this seemed to work really well. People might remember from last week's episode, Matthew Knight talking about at West Herts, they gave out temper dots, which are these little disposable thermometers to people who didn't have thermometers at home. But he's now recommending to all his patients that they want to keep a thermometer at home. And a number of people are also privately purchasing pulse oximetry. We've got a number of pulse oximeters out there. NHS England is organising distribution at the moment, so we're in a much better place on pulse oximetry than we were in the March-April period. There was another question, Lisa, I wondered if you wanted to come in a bit more about the data integration piece and the question about linking with systems, and it may be that Kuldhir and Tony want to add to that.
Sure, very happy to comment. So I think I've put a little bit of information there in the chat. Essentially, in terms of the day-to-day information, I think Kuldhir and Tony described really well that information comes through to a dashboard, which really helps clinicians to act on the dashboard because it's presented in a logical format with patients who are deteriorating highlighted prominently. So I think that deals with the day-to-day information and how it's translated. In terms of the longer term, how it integrates with different systems, this is a new area, and we've really pushed all of the companies that we're working with to figure out some answers for how we do this, and a number are now being tested. Some of those are linking to linking to a data layer. So if you've got shared care records or work with the LICRA across a geography, there are new efforts being made to link to data layers. Some organisations link to either for primary care system 1 or EMIS already, but these are new areas that have been tested over the last 6 months. So I think in a few months' time, it might be good for us to comment on all the changes that are recently being made in this area, so people can have a really full picture of all the developments and data linkages that we're doing. Chris may want to add some comments to that, because I know he's been directly involved in some of those pieces of work.
So around the data linkages, it's been a challenge, and I think the point I'm going to reflect on most is what Kuldhir said, is making sure you got the coding right at the outset. I think this is critical to this piece of work, and we'll going forward is one of the easiest ways to collate data from this, and we've had some interesting discussions, I think is the best way to put it, around the data points and the integration of data, but actually just getting the data and starting the recording and understanding the patient cohort is probably the most important.
Did you want to add anything, Kuldhir or Tony, to that question?
Yeah, I was just going to add, because I can see on the chat some people are asking about how do you go around capturing the information. To be honest, even as a practice, we were using MJOG, we're asking patients to let us know. So you can send a simple text saying your patients in the fairly quiet phase at the moment, please, we want to update your records. If you don't mind telling us your ethnic origin, height, weight, so we can update your records and bring them up to date. Start with the simple tools that you actually have at the moment. And equally over time, some of those additional tools may come into play about how you identify, put in protocols to work out which patients may be high risk, low risk. And for those practices that are familiar with emails, you'll have your little box in the right-hand corner, which will work as an alert. But again, it's about if we don't code in the first place, we won't be able to capture it, let alone on a patient basis or a patient population basis. But thank you.
And just to add to that, we are working, at least locally, on getting data back into the GP systems through one of the other digital providers that have existing APIs. It does require sort of manual bulk process, so it's not completely automated, but at least they've got that integration with both EMIS and System 1 for getting the data back in.
Great, and then there's a cluster of questions. There's a nice big thank you to Kuldhir. There's a cluster of questions about medications, about is not linking to EPS a problem? Did you track the medications? And did you see any reduction in antibiotics? So if I just give you those three together to comment on, that would be great. Kuldhir, I think. And Tony,
okay, so in relation to EPS, in relation to our local practices, so in theory, all primary care practices should have full access to EPS now, and hopefully that's been sorted out. I guess the key question is how do you manage that at the hub level? Right in the beginning, what we did was that we would have a very clear, as part of the SOP, a very clear task action where the message would go back to the practice and then someone would action the prescription that needed to be issued. If need be, at the end of the day, we were working as a collective team across the community. The hub doctor could pick up the phone to the GP practice and speak to the GP and get the prescription issued. In relation to antibiotic uses, actually, I would imagine for that cohort of patient, doxycycline and clarithromycin was used quite a bit. And interesting enough, that's now part of the respiratory pathway going forwards. We are currently working on trying to sort out EPS connectivity for our hub, or in other words, the community set up for those clinicians to be able to do the prescribing as well.
Great. And anything particularly about antibiotics or tracking meds?
So the antibiotic numbers were then thereby tracked through the medicines management team and the PAC data. So it will go back to the practice level data at this moment in time. But again, one of the reasons that we're trying to put our local hub as an entity onto the system is so we can then understand the medicines management side of it going forwards. But that's key, as you do with any kind of PCNs evolving, or those primary care networks evolving going forward. You'll need to do that as part of the workup. As part of long-term condition management, and as Tony will allude, when we're looking at diabetes working, is it working as a primary care practice or primary care network or a bigger level? We'll need to put those processes in place. But the key message is we didn't wait for things to happen to get started. We just
don't wait for perfection.
We just use the tools that we had, and that's why we absolutely did a forensic examination of our SOPs.
Brilliant. We've actually completed all the questions, so there is a chance to ask another. We have got time, and just while you're thinking about that, on Friday we came to the end of a 4-month procurement process for remote monitoring platforms. So we have just done a very comprehensive, fully compliant review competition really with the market, and we've identified over 80 approved suppliers and launched that on Friday. What this means is that for NHS organisations who'd like to procure, that process will take 3 weeks, not the 4 months of quite intense work that we've just enjoyed. It might be too strong a word perhaps, but anyway, we're there. So we would love people to use that. Have a look at those those suppliers. We launched a blog on the NHSX website all about remote monitoring, particularly in rheumatoid arthritis, with a really nice film on Friday. Do have a look at that, as well as the resource centre that I've mentioned. But we're hoping that that should make it really easy for local organisations to run a selection process under 3 weeks and be getting this up and running in a similar timescale to the very impressive 4-week process that happened across northwest London, which I know the people from the company involved think may be the fastest IT implementation ever in the history of the NHS. So please use that. We'd be delighted to offer any help that people would like in doing that. Well, we seem to have come to a natural end and answered all the questions. So it just remains for me to thank very much Tony, Kuldhir, and my panel of Chris and Lisa for your fantastic work that's happened. This project's been a total joy to be part of. We've thoroughly enjoyed it, and we definitely commend to anybody else looking at the winter that's coming and looking at patients across all groups, as Tony's pointed out, great for people with long-term conditions as well as people acutely unwell, to look at remote monitoring as being a big part of the future. Thank you.
Great. Thank you.